all about venetoclax and chronic lymphocytic leukemia.
What is venetoclax? Venetoclax is a small molecule inhibitor of protein called BCL2. The protein is really important for the survival of tumor cells. It's also expressed in normal cells, but the tumor cells depend on that for a number of reasons, and the levels of BCL2 are high in many hematologic malignancies. So what venetoclax does, it specifically binds to BCL2 protein through specific protein-protein interaction, and it prevents essentially collaboration between BCL2 and pro-death proteins. So what happens is that BCL2 is sort of being neutralized, and therefore the pro-death proteins that are naturally occurring in the cell, they're free to go ahead and kill the tumor cells. And because the leukemias are highly dependent on BCL2, this approach is really effective in leukemia and does not kill as much normal cells as some of the other, for example, chemotherapy does, because it's not as specific to the tumor cells as to the normal cells. That's how it works. It also called a universal sensitizer, because by lowering the threshold of cell death, it essentially increases the sensitivity or responsiveness to many, many different types of therapy, being a regular chemotherapy, targeted therapy, immune therapies. So right now, venetoclax is used in multiple combinations. So if you look at the clinicaltrial.gov website, there are probably more than 50 clinical trials that are ongoing with different combinations of venetoclax in different hematological diseases. So I think that's added value. So by itself, it may not be as effective because the tumor cells are very smart and they get around a single agent. But if you combine it with some other therapies, then it becomes really a killer and gets rid of leukemia.
How is venetoclax administered?
So venetoclax is an oral therapy. It's a pill. There are different strengths of pills. The approved dose is 400 milligrams. So the pills, the largest size of the pill is 100 milligrams. So the full dose, the patient would take 400 milligrams or 4 pills a day.
What are the side effects of venetoclax? Who is eligible for treatment with venetoclax?
It doesn't cause a lot of nausea or diarrhea. It's well-tolerated pill, even when it's used at 400 milligram dose. So very few patients have any particular gastrointestinal side effects. But, there are some patients who may have issues with their GI tract, with the stomach sensitivities or diarrhea. And of course, for those patients, having oral therapy perhaps is not ideal. So what are the common side effects of venetoclax? So there are two well-known side effects of venetoclax. So one is something called tumor lysis syndrome. Venetoclax has been approved for CLL a while ago, before AML. And CLL cells are truly dependent on BCL2. So you hit them with a little bit of venetoclax and they're going to die. So what happened in the CLL patients, because they have a large tumor mass, usually with the lymph nodes and high white count, that's kind of typical presentation. When they took venetoclax in the initial studies, there was so much tumor lysis, so there was so much tumor killing at the same time, very short time, so the drug works very quick, so within hours, essentially, that there was this complication called tumor lysis syndrome. So what happens is essentially when the cells burst open, they release a lot of substances. One of them is being potassium. And when the potassium levels are high, that can impair cardiac function and cause arrhythmias, and this could be lethal. So this became what we call black box warning for venetoclax, and the initial studies, in fact, in CLL were held for some time till we figured out how to give it safely.
So one of the biggest concerns with venetoclax is the drug is so effective that there is a problem in CLL called tumor lysis syndrome, when there's just this meltdown of the disease because it's so responsive to the agent that it just overwhelms and shuts down your kidneys. So to use venetoclax, we have to be very cognizant of that and very careful with that. So we define the risk of this happening based on the burden of the disease, the white cell count, and also the size of the lymph nodes. And based on that risk, we may be more careful on how we're going to do it. Some patients even have to be admitted to safely start venetoclax. But one of the most interesting points on this is that one would think that an older patient with a not ideal kidney function wouldn't be eligible for that. And it's quite the opposite. In reality, the study that evaluated venetoclax with obinutuzumab was really done in a group of patients that had comorbidities, had other medical problems, and didn't really have a perfect kidney function, and it was absolutely doable. So the reality is that most patients should be considered for venetoclax, even the older patients, even the patients with not the ideal kidney function, because it can be safely done even in those settings. So there's almost no patient, I would say, that maybe a patient who cannot take pills. I think that's the patient. Or a patient that for some reason cannot be admitted and you need to have the admission to safely start venetoclax. And even still, there are ways we can work around with it. So the reality is that it's much more the comfort level of the doctor that is prescribing it, understanding how to deal with these initial problems, the access to the clinic or to the site where they're going to be treated to be properly evaluated, get the hydrations, get the things that they need. So, but as a get-go, who should be considered, pretty much every patient can be considered for venetoclax.
How can side effects be managed?
So the side effects, again, there are two side effects. So one is this tumor lysis syndrome. So if potassium is high, we have special medications to bring it down. We have to repeat labs a few hours later. It's not just potassium. So sometimes something called uric acid is being elevated. And that's something we see when, in general, there's a lot of leukemia in the blood. And we use prophylactically agents that reduce uric acid regardless of even therapy. So there's certain measurements. Then the patients usually have to drink a lot of fluids to kind of wash out everything, the debris. So these are management of tumor lysis. Also phosphorus is another one that is easily managed. For the myelosuppression, I already talked about. So it's basically interruption of the duration of venetoclax management. But these are pretty much the only side effects. Again, we do not see any side effects related to the kidney, liver function, cardiac side effects. So essentially, the only clinically significant side effects is the risk of infection because of the low counts that develop with prolonged therapy. And then we also use growth factors sometimes. So when the counts are low and they do not recover in time, we do use generously the growth factors to help the recovery if patients are in remission. So that's another approach to manage the myelosuppression. There is a growth factor called granulocyte-stimulating growth factor. It's called GCSF. It has many different names depending on the company, but it's essentially injection under the skin, and you can give 1 or 2 or 3 injections like every day, and that facilitates the white count recovery. It's used routinely, for example, in patients who are undergoing stem cell transplantation to facilitate engraftment of the stem cells. So it's approved for the chemotherapy-induced low counts, white count particularly.
If you relapse after a BTK inhibitor, can you take venetoclax or vice versa?
So the question was, if I start with a BTK inhibitor, can I take venetoclax after? Or if I start with venetoclax, can I take BTK inhibitor? And the answer is yes. And this is usually what is done today. We have data. It's not phenomenal data because what happens in the studies that we use today were studies that were done in a time that patients that were started on BTK inhibitors on those studies had not seen venetoclax before, or the other way around. Patients that were treated with venetoclax on the studies had barely seen BTK inhibitors. So we don't have a lot of solid, large data, but we have reports, some retrospective data. So looking back on patients that were treated with venetoclax, had been treated with BTK inhibitors before, or the other way around. So we know that it works. When we're starting with BTK inhibitors, and we know that we're going to be taking them for a long time, there are 2 ways that they can fail, that we can have problems. One is that you are on a BTK inhibitor and out of a sudden you start having toxicities that make you stop. So we know that in those circumstances, now we have more than one BTK inhibitor, and we can, in the majority of times, try the other one and have the same disease control, potentially with less toxicity. Mainly if you're comparing a first-generation BTK inhibitor, ibrutinib, versus the second-generation BTK inhibitors like acalabrutinib, zanubrutinib. Now, if you progress in one of these agents and they're all the same class, they're called covalent BTK inhibitors. If one stops working, it's unlikely the other one would work. So then in this case, the next step generally is venetoclax. And venetoclax shows clear activity in these patients that are progressing on BTK inhibitors. The opposite is true. Patients that are started on venetoclax and get the 12 months, have great disease control, they will stop treatment because that's what we do. And now we're starting to see, because the responses are so good and so long, starting to see patients that having the disease show up again, have indication for therapy. And we have data that re-exposing to venetoclax works again. So we have that option of kind of the stop and go idea. You give venetoclax, stop, disease is controlled, you're off therapy for a while, eventually have indication for therapy, you start again. So on the study that evaluated venetoclax with obinutuzumab, we saw that those deep responses, on average around 18 months later, we start to see detectable disease from that MRD negative state, from the minimal residual disease that they couldn't even detect to the point that they can be detected. But then another 18 months to a point where they probably didn't need therapy. So it's quite a while. And re-exposure to venetoclax shows activity. But if for whatever reason you want to switch to a BTK inhibitor, yes, there's also data of BTK inhibitors working after venetoclax. Things are getting a little more complicated, but it's better now that we have a different class of BTK inhibitors that are arising. They're called non-covalent BTK inhibitors. So that class of agents work even when the other class, the covalent BTK inhibitors, don't work. So we have now the option of pretty much three classes that can probably be alternated. In the first line, we have the BTK inhibitors ibrutinib, acalabrutinib, zanubrutinib, or venetoclax-based therapies. And then in the relapse setting, you can flip around with those two, or very soon start having the option of the non-covalent BTK inhibitor called pirtobrutinib. A good amount of patients had absolutely no detectable disease, minimal residual disease. So when you evaluate that group of patients to the point that it had absolutely no detectable disease to some detection, on average was around 18 months. But doesn't mean they needed therapy then. It means that it was detectable. It goes back to when you were initially diagnosed. You may have had detectable disease, but you just watch. You kind of reset the clock, exactly the same idea. You go from an undetectable state to a point that you're eventually detectable, but does not mean you need therapy at that point yet. You again go to the beginning where you need to have indication for treatment before you get treated.
When is venetoclax reintroduced? Is it given for another 12 months?
We don't have that much clear data on what we do then. We can reintroduce venetoclax by itself, because then you're talking about the relapse setting. We have data on the relapse setting where venetoclax was combined with rituximab in a study called Murano. And now we know that obinutuzumab is better than rituximab. So potentially you could do the same thing again, obinutuzumab with venetoclax one more time. The role of this repetition is not really that clear, but probably depending on the time it took, how long it was, how well these were tolerated, we can certainly revisit the idea of re-exposing the patient to the same combination. If it was very well tolerated, gave a very long disease control, we can just try to re-expose again.